So prior to 2 years ago, we had no new drugs for over a decade. And now we have 8 new drugs approved in just the last 2 years. So the whole field has changed. And really what that means is that it is really important to make a specific genetic and molecular diagnosis for our patients with acute myeloid leukemia, because the treatment very well may be different. For example, in patients with untreated disease, it's important to separate those patients with de novo AML from patients with AML that is secondary, therapy-related, or more importantly, those patients with MDS-related changes, because the liposomal daunorubicin and cytarabine, or CPX-351, would be a useful adjunct to those. Knowing FLT3 status up front with the addition of midostaurin, or in the relapse refractory setting with sorafenib and now gilteritinib approved. IDH1 or IDH2 mutations, either upfront or in the relapse refractory setting, because these agents have been useful in not only relapse refractory leukemia, but ivosidenib just got an indication for elderly unfit for chemo in the upfront setting. Gemtuzumab, a drug that was approved, then removed, and now back, is also very useful for patients with specifically core binding factor mutations or cytogenetic abnormalities. So the world's different. It's important to be correct and not fast. Patients can wait a few days before initiating chemotherapy to try and put them into these different subgroups. And I think that's really where the improvement for our patients with acute myeloid leukemia is going to be coming from in the future.